Hi, we are here in Rome for the 15th International Myeloma Workshop. My name is Antonio Palumbo from Italy, Torino, and I'm pleased to be here with Philippe Moreau from Nantes, France. We are just coming from a very interesting session on monoclonal antibodies and humanized monoclonal antibodies. So the first question I would like to raise to Philippe is what was the major interest and starting with SLAMF7, which results have been presented?
Yes, in fact we heard about the results of the ELOQUENT-2 study. It is a randomized prospective phase 3 trials comparing in the relapse setting lenalidomide and dexamethasone, that is one of the standard of care, versus lenalidomide, dexamethasone plus elotuzumab. As you mentioned, elotuzumab is a monoclonal antibody targeting SLAMF7 that is always expressed by the tumor cells. And preclinical data show that this agent could be effective, especially in mouse model. Even though there is no single agent activity with elotuzumab, there is a synergistic activity with lenalidomide. So the results are showing on a very large number of patients that the addition of elotuzumab, that is provided IV, is increasing the duration of response. The progression-free survival, that was the primary endpoint of the study, is increased by almost 5 months. And what is quite interesting is that the impact on the response is lasting, not only at 1 year, but also at 2 years. And moreover, this agent is not adding a lot of toxicity. ELO is very well tolerated without impacting, for example, the infection rates. So that's very important. We have, of course, with all monoclonal antibodies, some infusion-related reactions, but really few, in fact, and mostly at the time of the first infusion. So this agent will be the first in class available in the phase 3 randomized study.
Oh, I completely agree that they show superiority over the standard of care, lenalidomide and dexamethasone. And certainly there is a major advantage for patients who achieve VGPR because they have a long-lasting remission. Of course, we have to probably wait the 3 years follow-up to confirm it. But at present, there is an excellent progression-free survival curve for this subgroup of patients.
Yes, maybe we can add as well that the survival data are not mature because the number of events is not reached. But as you mentioned, progression-free survival is a very important surrogate endpoint.
Yeah. You were presented, one of the presenters for the daratumumab symposium. So which is your home take message from this symposium?
Well, I think that we also discuss, SLAMF7, elotuzumab is a very important monoclonal antibody. But we also discuss on the results of daratumumab. Dara is another monoclonal antibody, fully human, targeting CD38 that is also always expressed on the tumor cells. And you have presented some data on the combination of Dara plus other agents, but we've also heard about Dara as a single agent in very, very advanced patients. And we do have 2 trials, one in Europe that was very recently published in the New England Journal of Medicine by the group from the Netherlands. And we also have another study coming from US, the Sirius study, in patients progressing and refractory to both IMiDs and proteasome inhibitors. And Dara as a single agent at the optimal dose, 16 milligrams per kg IV, is able to induce 30% response rate. That is very, very important for sure for the patients without any other treatment possibilities. And the duration of response is roughly 4 months. but the overall survival is something like 1 year. So we are adding something for sure when DARA is used as a single agent. And looking at the toxicity, very few toxicity as well with DARA. So I think that very, very soon this drug will be available, not only in US, but also in Europe. And we will have some early access to this drug for sure early next year. But you did present some data on DARA in combination with other agents. So can you tell us about your ideas?
Certainly the evidence coming from daratumumab are much early on than elotuzumab, because we only have right now phase 1 and phase 2 studies. And beside the single agent, there are some ongoing combination, especially with lenalidomide and dexamethasone. And daratumumab has been combined in relapsed refractory patient with lenalidomide and dexamethasone. And also here the results are quite impressive. 100% of response in all patients that did achieve at least the PR, with around 40 to 50% of VGPR, that probably this number will get better in the future, because with longer follow-up and more cycles, probably we will see even a better number. So certainly this is a major advantage and probably will change our treatment paradigm.
And in addition with Lendex, we are not increasing the toxicity of the combination?
This is another very important issue. Monoclonals antibody do not have additive toxicity over the standard chemo. Daratumumab has a slight of neutropenia, but not that important. But the major issue is that monoclonals can be clearly added to current treatment without major increase in toxicities. The issue is usually related to infusional reaction, and these some antibodies may have some more, someone else definitely less. But once again, as we were discussing, we are in the rituximab range in terms of infusional reaction. Yes. We saw also another antibodies, that is also the CD38 antibody, isutixumab. So how is your comment on this?
Well, the development of this antibody targeting CD38 as well is less advanced. I think that we have more data with DARA. The development is only in phase 1-2. We are hoping to have phase 3 in the near future. But, well, I think that the dose is also different. We've heard about the dose escalating study from 2 to 5 to 10 milligrams per kg. 10 milligrams per kg is the optimal dose with this drug. And it was immediately combined with lenalidomide and dexamethasone. And Dr. Martin reported twice some results at ASH and ASCO. And this drug is able to add something to Lendex. In patients refractory to Lendex, when you are adding this monoclonal antibody, you are able to overcome the resistance. So it is really something very fascinating. Although the response rate is not outstanding in the refractory population, I think that it will be probably difficult in the future to compare DARA versus the SAR compound from Sanofi, but I think that these two drugs are promising.
And also we saw some early data of combination of daratumumab with different standard treatment, bortezomib, dex, VTD. Which is your impression when you might use lenalidomide from one side as a counterpart, or bortezomib on the other side as a partner for daratumumab?
I think that the idea that we do all have in mind is that daratumumab can become a sort of, not a must, but a drug that should be added systematically to all the backbone regimens. We are using VMP in elderly patients, and probably it will be possible to do the VMP plus DARA in the future. We are using VTD, we are using Veldex, and it is probably possible to add DARA to these backbone regimens in order to increase the response rate, the duration of the response, like we did in fact almost 20 years ago in non-Hodgkin's lymphoma when rituximab came on the market. We immediately added rituximab plus the CHOP regimen with the R-CHOP. We did the same in the relapse setting with the DAP, with R-DAP, etc. So I think that probably DARA will be used as we are using rituximab in the non-Hodgkin's lymphoma setting. And in non-Hodgkin's lymphoma, we are using rituximab as a maintenance. So there are some studies already ongoing dedicated to DARA maintenance. So that could be also a plus for our patients.
Oh, well, thank you very much. Thank you for your presence here. As you can see, we are facing in myeloma is unbelievable. We already have 10 years of major improvement. We are still here with some even more interesting drugs coming, and I think this will be in the benefit of everybody, and I hope this will translate in a major clinical benefit, especially for our patients. Thank you very much.